Quality Improvement Initiative Final Project, the presentation. My name is April LInehan. I am a student at Excelsior College working on my nursing capstone. Professor Nancy Bellucci. The due date for this project is March 24th, 2024. Description of the problem. In postoperative cesarean section patients, how does educating nurses on appropriately applying abdominal preparation compare to no interventions, improve the rate of postoperative infections within 30 days. Surgical site infections. Over 60% of surgical site infections are preventable with improved adherence to already in place methods. Collins and Wick, 2019. Surgical site infections are a significant cause of morbidity and mortality after surgery. It is the most common and preventable complication after surgery. They are the leading cause of readmissions, and 3% of these patients will die. Mercal et al., 2015. So certainly after having a baby via C-section, the last thing one wants to do is have their patient, the mom, go home and develop a surgical site infection while they're trying to take care of the baby. There are many risk factors that increase a woman's likelihood of getting an infection, some are which we cannot change, as in diabetes, if they're anemic, if they've had huge blood losses. But there are a lot of things that we do before surgery that we can change the way that we're doing. And one of those things that I've noticed where I'm doing my project at is the abdominal preparation has been reported by some of the doctors and some of the nurses that not everybody was doing it the same way. So here we are learning how to properly apply abdominal preparation for a C-section to decrease the surgical site infection rate. So the QII project is taking place in a 250-bed community hospital on a labor and delivery unit in a suburb of Phoenix, Arizona. The labor and delivery unit does approximately 300 deliveries per month with a 30% cesarean section rate. So there are a lot of opportunities to develop a surgical site infection, and certainly a lot of opportunities for us to create a difference in maybe just changing a few of the things we do before surgery. The stakeholders for this project are all RNs on the unit. All of them circulate C-sections, so every nurse on the unit needs to be trained in this. During a C-section, there are OR surgical technicians, and they are responsible for gathering the supplies and kind of overseeing what the RN is doing while they're setting up to alert the RN if perhaps they've broken sterile technique or something, they're not doing it properly, or, if somebody drops something, they can pick it up. So they're certainly part of the program. The director of Women and Infant Services, her name is Audrey, and she is responsible for making sure that we have approved funding and that people can stay to get extra education. The manager of Women and Infant Services needs to be involved as well, as she needs to know which nurses may need some additional training in this. Clinical coordinators are also called charge nurses on some floors, and they are very important stakeholders in this project because if I need to review a little bit more on the proper technique, I might need to pull a nurse from an assignment just for a few minutes to make sure she can watch an abdominal prep in real time. And it's very important that I have the clinical coordinator's support during this process. The surgeons in the OR also need to be included. These are ones I had unfortunately forgot about in the beginning of the program, and throughout evaluation I realized that they do need to know as well. The proper abdominal preparation takes a little bit longer than what they're used to. So by educating them, I have been able to increase the likelihood that they will not be in such a rush when they are watching the nurse perform the scrub the proper way. The nurse educator for Women and Infant Services has been an important part of this program as well. She's also a stakeholder. Her name is Melissa. She is responsible for the policies and procedures to make sure that the current proper preparation is reflected in the policy. And the nurse navigator for Women and Infant Services does the follow-up phone calls after a patient's been discharged, and she is helping to track the infection rates. The nurse role and responsibility. So the nurse who is taking her patient back for a C-section needs to do a whole lot of things, but in regards to the abdominal preparation, she needs to identify any allergies to the preferred abdominal scrub, which is ChloraPrep at this hospital. The nurse needs to be wearing a long sleeve OR jacket and sterile gloves, using a light scrubbing motion over the incision line for 30 seconds or 1 minute for patients with a pannus. Using a back and forth motion, we're going to swipe the scrub wand upwards towards the umbilicus and toss the applicator. Grabbing the second ChloraPrep wand, repeat the incision scrub with patients for a pannus for an additional minute so that they get a total of 2 minutes on the incision. After the incision is done for an additional minute, you would go down one thigh and then go down the other thigh, and you end the process with a swipe over the mons pubis. For women without pannuses, they only need the 30 seconds. These are very few and far between. As we noticed at this hospital, the BMI tends to be a little bit higher. So we are trying to get into a habit of doing primarily the 2-minute incision scrub. And by breaking it up over 1 minute going up and 1 minute and going down, the nurse's arms are not as tired. It's 2 minutes is actually a long time to be moving your hand back and forth. So we do 1 minute and up, toss it, 1 minute and down and toss that. Then the solution needs to dry for 3 minutes. And to use the timer, we've been using the Apgar timer on the baby warmer, which is set up in the operating room. For the timer, as far as the incision for the 1 minute and the 30 seconds, nurses have been directed to use the clock right above their head in the operating room. Integration of evidence. So in order to get this project kind of up and running, what was most important was proper education. And I did look into different ways of how to integrate the evidence-based practice, what was the best way to teach nurses a new skill. So I learned from Ayub Khan in a 2022 paper that they wrote, the use of a tiered learning model has been shown to improve learners' retention. The opportunity to move past visual to a skills lab and eventually to a real-life scenario is shown to bridge the gap between education and practice. I have been doing this by doing the presentation. The ChloraPrep representative came out for a day and did as many staff as they could. I have been following up with one-on-one or a small group review of all of that information. The wands are available to, they're used, so they're just open to, kind of practice a little bit, like grab it, and there's a laminated board where people can practice going over an incision site for their proper time. And then I have been going into the operating room with the nurses, and the first time I'm in there with them, I'm there for support. Do you have any questions? Where are you going to do this timer? And then the time after that, I'm more of an auditor, is that education sticking? And so far, I've seen really great results. People are very receptive to an extra set of hands and someone who's available in the operating room to ask questions to. And someone also has another set of eyes, say, okay, where are you? How long have you been scrubbing that? How do you know it's been 30 seconds? Which clock are you looking at? So this all obviously included updating all staff RNs on proper application of ChloraPrep in the operating room. The RNs are the ones that actually do the preparation. The rest, for the scrub techs, I've just included them in on the fact that we are using 2 wands now, and that the preparation can take up to 2 minutes if the patient is a larger BMI with a pannus. And we've been reinforcing training with that little laminated square with the incision. And again, I have been going in and out of the OR, monitoring and assisting and just kind of being there in whatever level the nurse wants. There are some nurses that have been doing this for years and they've been doing it properly. And I just kind of go in. She goes, you can just watch me. So I just observed and it was done properly and moved on. So there is that. The description of the initiative: to provide all OR RNs the education needed to correctly apply the pre-surgical abdominal preparation. By ensuring that all surgical sites are prepared properly and the same consistently, this will allow further exploration if the SSIs continue to rise. There are several steps to perioperative preparation. There's pre-surgical antibiotics, there's a shave and clip, there's chlorhexidine wipe that we use beforehand. There's sterile technique within the OR. So these are all kind of issues, other things that we can look at. So hopefully this will tackle most of it. And the goal is to decrease the SSIs after cesarean sections for patients with minimal risk factors. And I thought we would start there with just the minimal risk factors. And this kind of works on a future slide about Cotter's 8 steps, but trying to get a small win here. If we can kind of get just the easy ones with few complications to have good results, then we can move on to patients that have more complications. The significance of this QI project is surgical site infections are preventable complications of surgery. Readmissions to the hospital create financial hardship. This is across the board, not just for C-section patients. This is within any surgery. In the case of the surgical site infection after cesarean section, the whole family is impacted. There is decreased maternal bonding due to pain and/or infant not being allowed in the hospital if the mom does get readmitted to the hospital. And there is a strain on the family unit with a primary caregiver being unavailable, whether she is in bed in pain, receiving home health visits, wound health, wound dressing changes, IV antibiotics, or if she's actually in the hospital, she's not available. Decreased maternal bonding opens up a Pandora's box of many issues throughout a child's lifetime. It interferes with breastfeeding. They even say, it interferes with simple things like just reading to your babies or, talking and singing to them. If you don't have that early time when they're babies that you do, the whole unit suffers. Description of the team. The team is RNs that currently serve as preceptors on the unit. These are the people I first met with, the clinical coordinators, or otherwise known as charge nurses, the surgical technicians who are in the operating room, making sure that the proper things are available. My mentor was available to me for the team. I did meet with one of the surgeons, and I have now a working relationship with the ChloraPrep representative. His name is Michael. And to get started, we had a couple brainstorming sessions, just kind of asked, what are you doing now? And I think the biggest surprise for all of us that were talking about it at that time was how varied everyone's preparation was before a C-section. So it was pretty easy to get the team to kind of buy into the whole idea that we all need to be on the same page and doing the same things. And perhaps that might alleviate some of the surgical site infections that we're seeing after C-sections. The team also brought forth lots of questions of different scenarios that we really need to be accountable for. We talked about emergencies. We talked about women who were the larger BMI, and that has really been a big focus, is how do we get that timing done? How many applicators should we be using? If a woman has a very large BMI, we found out it's okay to use, two applicators, at least 3, sometimes 4 if you really need to. It's more important to get it all done, get the proper amount of solution all over. And we also talked about the skin retractor. We use a Traxi to lift up the pannus so that the incision site is easily visible for the surgeon. The change theory I chose to use for this project has been Kotter's 8 steps of change model. I'm just going to go through each little step here and tell you how I've been able to incorporate it. So by creating a sense of urgency regarding increased incision infection rates, we went over how many patients have been getting infections after their C-sections, and also realizing the variances of all the RNs on the floor really created a sense of urgency of, well, maybe if we can all kind of get in line here, we can figure out if it's us that's the problem, or does the woman just have so many risk factors she might just develop an infection at that surgical site anyway. Building a team. By having these group discussions, I was able to create a small handful of people that were willing to kind of work with me going forward and keep answering my questions and allow me to follow them around on the floor, not just my mentor, because sometimes she's working while I'm trying to follow somebody around. So, building up my team of people who are finding this important. The nurse manager has been very helpful as well. And then Cotter also goes on to form a mission. And so I tried to keep it simple. Our first mission was just to train all the OR team members in the proper application of the ChloraPrep. Finding volunteers. These are people who are eager to want to contribute. Fairly easy, again, to do. A lot of people on the floor had a lot of ideas on how they did it before, what they saw at other facilities, and they were more than happy to contribute to some problem solving. And removing barriers to learning is also very important in Kotter's change theory. And that has been different for all the nurses. I think what I've seen the most is the newer nurses feeling like they were supposed to remember everything the first time they were taught. And by starting from scratch, saying, not only are you not doing it right, but almost everybody on the floor hasn't been doing it right. So let's all start from scratch right here. So that was a big barrier. Also, involving the surgeons in on the education, having a surgeon breathing down your neck while you're doing a preparation that's taking longer than what they're used to is a difficult learning environment. So by incorporating the surgeons into the education, we've been able to get them to kind of back off a little bit so that the nurses feel more comfortable applying the applicator. And short-term wins and encouraging the team to persevere. Like I previously mentioned, we're focusing just on low-risk individuals. So those are scheduled C-sections with no other complications happening. So by seeing if we can get that narrowed down to a lower percentage, then we can kind of move forward and say, okay, that didn't work or that did work. What else could we do? And if this change is helpful, then we could go on to the next thing. Okay, so this helped this. Now let's get into these women with high risk factors. What's important for them? Let's make sure those antibiotics are on board, or whatever the evidence suggests, that maybe we can do better at. And the last step is instituting a change. And for me, that means a lasting change, and one that once I'm done and I'm finished with this project, they're still using the proper technique. Incorporating the perspective of the interprofessional team. This has been really one of the most important steps to initiating this whole QII. Getting feedback from the OR team members about the changes and what they saw as problems. Being able to talk as a group about the problem solving for the obstacles. And again, we go back to the larger BMI with the skin retractor and how many applicators are needed and how do you use the retractor and still keep a sterile field. Standardizing preparation is needed and desired. The evidence-based practice is that the same thing needs to happen each time you're in the OR. And by learning to do that properly the first time, once you get a standard and you know your routine and you do it exactly the same way each time, we're going to tend to see fewer discrepancies as nurses go on to train other nurses. If everybody's doing a 2-minute prep and we're all using 2 applicators and we're all doing it the same way, the new nurse coming in that's what she's going to learn as well. So this can be, a sustainable Again, informing the surgeons of the changes so they understand why preparation seems to be different. That actually happened in real time. I was helping a new graduate nurse in the OR, and the surgeon was looking at me saying, well, I don't understand why she's doing it for so long. So that was a big eye opener. And I thought, wow. I know this surgeon pretty well, and he's questioning me. I imagine the new nurse probably feels a little intimidated, and perhaps she might have normally cut her scrub time short, but I was there to intervene and say, hey, you know what, we've been doing it wrong. So let's cut down our infection rate, and we're going to do the 2 minutes, and we're going to use 2 applicators. And just by including them in on that conversation, they said, oh, okay. And they stepped back and did something else for a little while. Including the OR technicians was super important as well. They usually just have been leaving 1 applicator out. So just making sure that they knew that we would now need 2 applicators, and the nurse should be wearing a long sleeve shirt and sterile gloves. And it is okay to say, you don't have your jacket on. Can you put your jacket on before you do this preparation? That is part of the policy, and that needs to be adhered to. Implementation of the plan. So how have I gotten here so far? The ChloroPrep representative was very easy to get a hold of, and he was very eager to come out to the site to do some training. He was out on February 29th, and he did 6 classes for day shift and a couple for night shift that were trying to go home. And I worked with him through all 6 of them so that I felt comfortable, and he felt comfortable with me continuing to relay the information for the individuals that weren't there. So I have been hosting little individuals training sessions with my little laminated incision board and my already opened ChloroPrep things, walking around the unit. We just do a very short little quiz following the education, just to make sure that the nurse understands what the changes are and what they need to do. How many sticks do you use? How long do you use an incision? If the woman has a pannus, what does that look like? How long does it need to dry for? Do you have long sleeves and sterile gloves? It's really pretty simple. So it's not been difficult. It was just everybody was just kind of doing their own thing. And from here, I'm starting to obtain infection rate during discharge phone calls. The nurse navigator will be doing this. I have given her a list of all of the cesarean sections that I've witnessed that have followed the proper prep. And during her follow-up phone calls, she is asking them if they have had any surgical site infections. She usually starts a week and a half after the patient's been home for about 10 days or so. So I should be starting to get that information in soon. And we can see if it's been successful. Integration of health information technology. These are some ideas that were generated from doing this project that could be helpful to the hospital. The biggest problem that all the nurses shared, and one that I have witnessed as well when I used to work there 3 years ago, is there are 2 different systems for charting, and the 2 different systems do not talk to each other. The labor and delivery information and charting system is in one computer system, and it does not flow over to the other system that the rest of the hospital uses. So for their postpartum stays and the follow-up phone calls, the information of actually what happened during labor, what happened during the surgical preparation time is not included in that main system. So it would be wonderful. And we've been talking about it for years, and it's just not in the budget, but it would be wonderful if those 2 systems could talk to each other so that a full picture of the pregnant patient would be able to be seen by anybody looking at the chart, not just those who have access to the labor and delivery. It's called a QS system. The follow-up phone calls are done by a nurse navigator, and they are tracked in the current EMR, which is Cerner, and the pertinent information is readily available to her, except for what kind of preparation they had, how many applicators were used, did it dry on time. All of that stuff is in the other computer system, but it is flagged enough for the nurse navigator to see, did the patient have a C-section, and was wound care involved? And she can do the follow-ups from there. So hopefully they'll get systems that talk to each other. I don't know. We'll see. It's expensive. It's hard to get a hospital to spend some money on that. And that's not my project this time. Maybe someone else can do it. Resources needed to facilitate this plan. This was such an easy and financially feasible plan for the hospital. They were more than happy to have me come in and do it. The ChloraPrep representative's time, I just needed to arrange for him to come out. That is free of charge to the hospital since they are a vendor in the hospital. You can have them come out as often as you'd like, and it doesn't cost anything. There were small amounts of incremental overtime for staff to receive training after their shift is completed. I tried to get there at change of shift so I could catch people before they went off duty, but if they were busy charting or giving report and it was a little afterwards, I did have permission. They could get it. Training didn't take long, about 10-15 minutes. So they were allowed to have that overtime to complete the training. The number of applicators being used is more than they had previously been using. So going from 1 applicator to 2 per patient is a little bit of a financial burden for the hospital, but they have not mentioned that it was an issue since using 2 applicators is the standard of care. And my time going in and auditing and teaching and supporting all the staff, which is completely free for them because I do not work for this hospital. I am going in just simply to get my project completed. So they are very happy to have me and training it. It's been a really nice time. And since very minimal resources were needed for this plan, I've had no issues with getting anything implemented. Like I said, I'm free. The representative was free. There's a little increase in the budget from a little overtime here and there, and the number of applicators being used, but they need to comply with the product guidelines. So it's not really a line item that's up for debate. So it's been a lot of fun being there in a volunteer capacity, because I can kind of just help everybody do all sorts of things. So it's been very nice. And they have been so happy to have me there. It's been a good time. Implications for nursing and healthcare. By going through these little classes and teaching, this little bit of stuff. So empowering nurses to follow evidence-based practice allows them to play a part in the surgical site infection reduction. Just being able to see the light in some of these, especially the new graduate nurses, like I never knew how to do that right. Thank you for coming in and teaching me how to do it right. I didn't know I could play a part in them not getting an infection. I thought it was the surgeon, they needed to be sterile, really bringing out the evidence of how the ChloraPrep works, why it needs to stay on the body so long, why it's important we do what we do with sterile gloves, really has empowered these nurses and to stand up for themselves, and to say, oh no, this is the right way to do it. By encouraging education and problem-solving dialogue, the team cohesiveness has been really promoted. After completion of this QAI, the organization can then look into providing similar education for the other perioperative steps. I mentioned hair removal, antibiotics, and the chlorhexidine wipes. There's also a vaginal prep you would use for laboring women who move on to C-sections that could probably be done as well. So we tackle one little portion, like I said earlier, in those Cotter's 8 steps, small wins, small victories, and we can keep moving. The culture of safety. In order for this to be effective and promote a culture of safety, we need to have actively engaged leadership, which is why I really wanted the director and the manager and the clinical coordinators to be full on board with me being there and learning this the new guidelines, which have been apparently guidelines for quite a while. We're slow behind the times. So having the leadership be actively engaged and saying, yeah, great, go ahead, go listen to her, go in there and go practice. Very helpful to promote that culture of safety. It encourages ongoing dialogue between all of the nurses. Oh, hey, I was in there. Which clock did you use? I'm going to use the one over here. Did you press the APGAR? Oh, the nursery nurse pressed the APGAR for me. Like all these things it's encouraging a lot of on-unit dialogue. Training all members of the team adds to personal accountability. If you know that you're going in and you're doing a preparation and everybody else in the room has been trained in the proper preparation, chances are you are going to do it right. You're not going to try to make a shortcut or anything because everybody in that room knows exactly how it's supposed to be done. And since the training is new and all of the team members are learning all at the same time, feedback from peer is viewed positively rather than punitively. So if you're in a room, and I've watched one of the nurses, kind of get up on the incision line with a dirty applicator. I just went over, cracked open a new one, hey, I saw that you accidentally did that. So just let's try it again. Here's another applicator. Let's do that incision site again. And when you do that last area there, do not drag it over. It'll contaminate it. And everybody's been very receptive. Another way to improve the culture of safety is when the nurse feels engaged in change, they are more likely to adhere to the changes in their practice. So all of the nurses that feel that this is a worthwhile project, that the evidence shows that this is the right way to do it, they've been listened to, they've had questions answered, they've come up with scenarios, people have been working with them to try to make it feasible, they're more likely to go ahead and stick with that practice. Evaluation. Based on staff quizzes, information has been presented effectively. Direct support will continue to be offered. I have another 10 hours that I will be on the floor going in and out of C-sections, at least 10 hours for the course requirement, but I will continue to go until everybody is completely comfortable. Direct observation has provided opportunities to troubleshoot in an effective manner. And the follow-up phone calls to track infection rate on observed cesarean sections start this coming week. She said she would start Monday. Conclusion. This QII has been eagerly embraced by all OR staff. Including the surgeons into the educational plan has fostered communication and patience on their part. Changes are being made consistently to follow manufacturer guidelines for abdominal preparation. Being on the unit and performing direct observation has given me the opportunity to problem solve in real time to create solutions that work in practice. The team continues to have questions regarding the use of the product when a skin retractor device is needed. Continued use of the ChloraPrep representative is needed. There's a lot of confusion around this, a lot of conflicting information depending on who you ask that question to. Even the different ChloraPrep representatives are giving different answers. So using a skin retraction device, which this hospital uses a system called Traxi, with the ChloraPrep, I need to get back in touch with the ChloraPrep representative and get specifically what they recommend for this hospital for that device with their abdominal preparation. And what I have learned, change needs to be supported by evidence of why a change is needed. Had I gone into this project and just said, here's the new ChloraPrep representative, here's how we're going to use it, and just kind of told people what to do, I don't think I would have had the reception that I've had by including to them what the evidence shows. The infection rate is rising. How can you, as their nurse, have a role in decreasing these infection rates? I also learned that different nurses have many different learning needs, and they need to be supported in a manner suitable to them. I previously mentioned the nurse with a lot of experience who's been doing it properly does not need me hovering over her to make sure that she has sterile gloves and a jacket on. I mean, I can take a quick peek sitting in the little chair in the in-between room, and I can say, okay, she's got the gloves on, she's got her jacket on. Look at the clock. Oh, she's doing 2 minutes. Look at the clock again. Okay, she's drying it for 3. I don't need to be over her head. While the newer nurses really need to have me hand on hand almost, and that's important that each nurse learns differently. Some feel very threatened. If I'm in the room, they feel, oh, you're watching me and I'm nervous. So I've had to, just watch through the window and make sure that they're following proper technique. Including all stakeholders is essential to eliminating barriers to the nurse's success and making changes. And again, that goes back to all the support on the floor, as well as the surgeons and the OR technicians being there. If everybody knows exactly what the nurse needs to be doing, they will all rally and support the nurse in doing it well, because nobody wants infections. and the importance of acknowledging all feedback and make change as the plan progresses. There were a lot of things I had in mind. I thought, oh, we'll do it like this, we'll do it like this, we'll do it like this. And when the nurses on the team said, oh, but sometimes this happens and sometimes this happens, I can't see the clock over there. How do I set the timer? Being able to kind of stand there and say, oh yeah, okay, you can't see the clock from this side of the body. Okay, how can we do that? Do we need to move the clock? Do you wear a watch? Can we use a different clock? Should we use the APGAR timer on the infant warmer? So really important to actually be in there and listening to people. And when the representative said to do the 2 minutes incision first, and everybody was trying that, and they said, my arm is so tired, I can't do this whole 2 minutes, and then up, and then another, and down. So that's when we learned we could split that up, do 1 minute and then another minute later. So really listening to the feedback and making changes to the plan as it's being implemented. The nurses have been very receptive to making lasting changes in their practice as far as the abdominal preparation for a C-section goes. And there are my references. Thank you very much for your time today. I really appreciated the opportunity to be out there and to work on this so closely and really feel like I'm making a difference. So thank you very much.